Good evening, everybody. We'll get started in just a moment. Just gonna let everybody come in. Good evening, Sam. How are you tonight?
Good. How are you doing?
I'm good. I almost said happy Monday, but it is Wednesday, so
It feels like a Monday.
it feels like a Monday. But this is going to be an awesome presentation. We're super excited. So without further ado, welcome to tonight's Wu University webinar, starting Scleral Lenses Made Simple with Dr. Samantha Hornberger. I'm your host, Dr. Jennifer Stewart. It is my great pleasure to introduce Dr. Sam Hornberger. She graduated from Indiana University School of Optometry in 2005. She was born and raised in Indiana and is a Hoosier through and through, loving Bloomington so much that she remained there to complete residency training with a focus on cornea disease and contact lenses. She owns a private practice in Dearborn County, Indiana, that she opened cold in 2013 and recently expanded to be able to serve more of her hometown community. She's the president of the Southeastern Society of the Indiana Optometry Association, serves on the Speakers Board Bureau for several companies, as well as doing speaking engagements for practice management and continuing education. Her passion is sharing knowledge with and promoting her fellow eye care professionals to help them be more successful, and is grateful to also be providing high-tech but approachable eye care to her hometown community. Most important, she's my Disney buddy and is a wonderful speaker, and I'm super excited to welcome her here tonight. So with that, I'll turn it over to you.
Oh, thank you, Jen. I am so excited to be here. Showing my financial disclosures here. And I'll leave this up for just a second. This is just my email address. I'm going to show it again at the very end of the presentation. So no worries if you don't get it right now. So I'm super excited to present Starting Scleral Lenses Made Simple. In talking to a lot of my optometrist colleagues who don't fit scleral lenses at this point, there's a really common thread, and that is, a lot of people know that scleral lenses are amazing. They know that they can be life-changing for patients, but they're really intimidated by the process of getting started if they've never fit scleral lenses. They didn't fit any in school, or maybe they've been out of school for a while. The process can feel really overwhelming. And so my goal for tonight is to take you through the process kind of in the lens of a beginning fitter who's never really fit scleral lenses before, make the process feel more approachable, a little bit easier, and give you just some basic fitting principles and some basic troubleshooting tips to allow you to, next week, find those patients that can benefit from scleral lenses and just jump in and get started, knowing that it really doesn't have to be that hard. Starting to fit scleral lenses can absolutely be a simple thing to do. So when we talk about scleral lenses, we're talking about rigid lenses, of course. Scleral lenses aren't the only lenses in that category. So just to kind of review the different types of lenses that we talk about when we have that category of rigid lenses, we've got corneal, right? So corneal RGPs, or corneal gas perm lenses, those are going to fit completely within the bounds of the cornea. So every bit of that lens is going to rest on the cornea. Obviously, we know that with that can come lens awareness and things like that. Then we've got corneoscleral lenses. And for the purposes of what we're going to talk about tonight, then we have scleral, or what some people call full scleral lenses. These are lenses that rest completely on the sclera, vaulting over the complete cornea. Within the category of scleral lenses, we kind of have two categories in that as well. The first one is going to be your mini scleral lenses, and that's really what we're going to spend most of our time talking about, pretty much all of our time talking about tonight. Mini scleral lenses, those are lenses that are up to 6 millimeters larger than the horizontal visible iris diameter. And then we've got another category of large sclerals, and those are just lenses that are more than 6 millimeters larger than the horizontal visible iris diameter, or HVID. Really, the only reason that you might pick a large scleral is if you had of a lot of protrusion in the cornea. If you had severe ectasia and you had something that required more lens vault or more clearance. But those are types of rigid lenses. And again, for tonight, we're going to concentrate on the scleral or full scleral, and we're going to talk mainly about mini scleral lenses. Let's talk a little bit about scleral lens terms. Some of these terms, if you fit gas perm lenses, corneal gas perm lenses, you're going to be familiar with already. Some of them you might not be as familiar with. First one is the optic zone. You can see there in the graphic, it's the middle portion of the lens. It's really where the vision correction comes from. But we're familiar with optic zone because traditional RGP lenses have an optic zone as well. But if we think about the lens as a bullseye, it's basically the center of the bullseye. The next term to know is liquid reservoir. I'm going to use that interchangeably with the word clearance. But basically, because this lens vaults over the entire cornea, we're going to fill it with a liquid filling solution. We'll talk a little bit more about the types of filling solutions that we can use. But between the front of the cornea and the back of the scleral lens, that's going to be filled with this liquid reservoir. And when we talk about clearance, we're really just talking about the amount of space that's between the front of the lens and the back of the lens and the front of the cornea that's filled with this filling solution. When we talk about scleral lenses, we don't really talk in terms of base curve like we would with corneal RGP. And we're going to talk in terms of sag or sagittal depth. So unlike a traditional curvature where we're talking about steepness and flatness, when we talk about the sizing of the lens as it comes to curvature, we're going to talk in terms of sag or sagittal depth. It really just means how deep the bowl of the lens is. Transition zone. So this is a term that we don't really hear very much in relation to corneal gas perms, but transition zone is basically the area where our curvature is changing from the optic zone curvature in the center of the lens to the haptic or landing zone curvature at the edge of the lens, or where the lens is actually going to land on the sclera. And that's all it is. It's just transition and curvature. Most of us know that the cornea and the sclera have two very different topographies, two very different curvatures. And so that transition zone is important to get it landing the way that we need it to on the sclera. And then that landing zone, also called haptic, is literally where the lens is just sitting on the sclera. So who can benefit from scleral lenses? I mean, I think we all know that scleral lenses can be absolutely life-changing for some patients, but who are those patients? Are we seeing them in our practice already? Who can really benefit from these lenses? So some indications for scleral fitting. The first one is just vision improvement. Vision improvement is probably the number one indication for scleral lens fitting. Usually the need for that vision improvement comes from having an irregular cornea. There's lots of different reasons that we might have an irregular cornea. And what we're really talking about is, a cornea whose topography is not symmetric. Over here on the right side, we see a cornea who's much steeper inferiorly than superiorly. Obviously, this is a cornea with ectasia, but sometimes that asymmetry is not as remarkable as that. Sometimes it's just what we'll call irregular astigmatism, but it can still make a big difference in the quality of vision that patients are getting. So some things that can cause irregular cornea, obviously keratoconus, keratoglobus can cause irregular cornea as well. Pellucid marginal degeneration is a corneal irregularity with ectasia. Post-refractive surgery, we can have irregular corneas. Obviously, refractive surgery like LASIK, like PRK, in either of those, the shape of the cornea becomes more oblate, and that can cause some vision issues. We might have a wrinkle in a LASIK flap that's causing some vision issues. Post-radial keratotomy, or RK, these patients can really be helped quite a lot by a scleral lens. Those corneas are often very irregular, very oblate, and a lot of times really unstable. I mean, a patient who has had RK surgery, sometimes they have a different prescription at 9 a.m. than they do at 4 in the afternoon, simply because the curvature of their cornea changes as the day goes on. Then we have patients who've had corneal trauma and scarring. Corneal trauma can come from all sorts of things. I've had patients with corneal trauma and scarring from microbial keratitis or fungal keratitis. Sometimes it's simply just a trauma or a central foreign body that's left a scar. So lots of reasons you can have scarring. And then we have our post-transplant, our post-PK eyes. Oftentimes, those patients who are post-transplant, even though the transplant has helped with clarity of the cornea, they're often left with irregular astigmatism because of the suturing. And that makes it really difficult for them to get quality, sharp vision with traditional glasses, traditional contact lenses. Second indication we'll talk about for scleral fitting, this is ocular surface coverage. So for patients that have exposure, this can be a big deal because with a scleral lens, obviously we're vaulting that cornea, and the cornea is being bathed in this liquid fluid reservoir. So not only does the scleral shell give protection, but patients get the benefit of that constant fluid reservoir. So if a patient suffers from severe dry eye, if we have a Sjogren's patient that has severe dry eye or sick because of that, when that cornea gets bathed in this fluid reservoir, when it's been so deprived of tears, it can have a really restorative effect on that ocular surface. Not only can it make the cornea healthier over time, but obviously it reduces discomfort quite a bit. Then we have patients that have exposure issues. So maybe a patient who lost part of their eyelid, or they've had a lid surgery and now they've got some lag ophthalmos, or maybe a patient who's had Bell's palsy and has incomplete closure. Those patients can, suffer from significant dryness because of exposure. It can start to cause some corneal scarring and things like that over time. And fitting those patients in a scleral shell with that fluid reservoir really makes a huge difference in not only comfort again, but corneal condition as well. And then you want to think about your patients who have trichiasis, entropion, ectropion, maybe those patients who either can't have or aren't interested in having surgery to fix those things. Protecting that cornea, again, without scleral shell, can bring them a lot of comfort and can keep the lashes and the lids from doing damage to the corneal surface over time. Last one that we'll talk about is cosmetic improvement. I would say this is probably the least utilized reason for fitting scleral lenses. But again, I feel like I'm repeating myself, but life-changing is not too big a term to use for the effect that these lenses can have on patients. For cosmetic improvement, we can paint and tint scleral lenses, similar to how you can do that with custom soft contact lenses for things like photosensitivity with albinism or aniridia. You can create an iris by painting on the surface of these lenses with an open pupil if necessary to actually lessen the amount of light that's coming in. Like in the case of aniridia or albinism, you could do a painted pupil if it was just a non-seeing eye that you wanted to match the cosmetics of the fellow eye. You could do that. Cosmesis in patients who can't wear a soft lens, or those patients that require both the cosmesis and the visual benefits of a scleral design. So if you had a significantly scarred eye that could actually see better and have some visual improvement because of a scleral design, but that patient wanted to mask some of the scarring and have better cosmesis, this would be an option for them too. So those are the indications for scleral fitting. Next, let's talk about contraindications. So in my mind, there's only one on this list that is, if not a total contraindication, it's close. I would say a near total contraindication. And to me, that's low endothelial cell count. Because of the way that a scleral lens fits on the eye, there is very little to no movement of that lens. So we're not getting the normal tear exchange and oxygen exchange that we would with a corneal gas perm or a traditional soft contact lens or even a hybrid lens. Because of that, we are not getting those oxygen molecules into the tears and then brought up under that lens with a blink. Obviously, we want the filling solution to stay put in there. And if we had too much movement, that filling solution would leak out and things that we don't want in would leak in, possibly causing fogging and all sorts of stuff. So that means that the oxygen delivery with a scleral lens is not as high as some other lens designs. So if you take an eye that is challenged because of low endothelial cell count and you put a scleral lens on that, you're going to challenge that cornea even more. So you want to take a good look at the endothelium before you fit somebody in a scleral lens. I know some doctors that will actually do an endothelial cell count before they fit somebody in a scleral if there's any question. If you've got the equipment to do that, absolutely, that's a great idea. I don't have that in my office. And so what I do is just make sure I take my time and give a really thorough examination to the endothelium to just really assess the health of that endothelium before I fit a scleral lens on that. The second one is Fuchs dystrophy. I don't know that this is necessarily a contraindication. I just got done telling you that I would hesitate with low endothelial cell count to fit a scleral lens. However, with Fuchs dystrophy, there really is a wide range of severity. Okay, so if I had a patient who really didn't have any corneal edema, I was just seeing, let's say, trace, so grade 1, maybe even grade 2 gutata, but they didn't have any morning blur. I wasn't seeing any, the cornea wasn't edematous. I probably would go ahead and fit that patient with a scleral lens if I felt that they would benefit from it. I would just make sure that I'm monitoring that corneal health really closely. Maybe if I had grade 3, grade 4, certainly if I had an edematous cornea, I would not fit a scleral lens on that. But I don't think that Fuchs dystrophy is going to necessarily keep me from fitting a scleral lens if I really think somebody's going to benefit from it. The next one's kind of a question mark too, and that's glaucoma. So there are some circles of practitioners that say that patients with glaucoma will have an increase in pressure or poorer, more progression over time if fit with a scleral lens. You can find literature both agreeing with that and disagreeing with that. I think the jury is out still. But if we think about it, with how a scleral lens fits, where it's sitting on the cornea, the sclera and conjunctiva, putting a little bit of pressure, there's a theory that it could be kind of pushing against the anterior chamber angle, trabecular meshwork, and decreasing aqueous outflow. What I would say to that is if I had a patient who had glaucoma and was wearing a scleral lens, obviously anytime you have a glaucoma suspect or a patient who's been diagnosed with glaucoma, maybe somebody with ocular hypertension, you're following them anyway. You're doing OCT, you're doing visual fields, you're checking their pressures. So all I would say about that is you're going to continue to do the same things that you've been doing. If you feel like you have good control and you're seeing progression, maybe just let that be in the back of your mind. If they wear a scleral lens, that could be part of it. Maybe while they've got that lens on, their pressure runs a little bit higher and you don't have quite the pressure control that you thought you had. So it's just something to, I think, be aware of. But, again, the jury's kind of still out on that one a little bit. Dexterity issues. People can learn to put lenses in all sorts of amazing ways. I mean, there are patients that, put contact lenses in with their feet because they don't have arms. But dexterity is something to be aware of. I'm going to show you some videos later of how to insert a lens, and you just want to be aware of it for your patients when you're training. Issues like arthritis and things like that, it can make it more difficult for patients, for sure. I have in the past actually put together makeshift insertion devices for patients that were struggling with hand dexterity by just taking a basic plastic cup, flip it upside down, put a hole in the middle, put the insertion plunger right in that hole, and it holds it for them so that they've got two hands to hold upper lid and lower lid. So I think dexterity is something that for the most part we can overcome. And then the last one is corneal neovascularization. So I told you, a minute ago that the oxygen delivery with scleral lenses is not as high as it is with, say, a corneal GP or traditional soft lens, or even a hybrid lens. So you want to be aware of that oxygen delivery. If patients have corneal neovascularization, there are ways that you can mitigate that for sure. You can go as low a clearance as possible. You can use higher decay materials. There are ways that you can do that, but certainly if they have corneal neo, it's something that you want to be aware of and be monitoring. I actually have a patient right now. I just came in a year after I did his scleral fitting. Just saw him today, as a matter of fact. He had been in a hybrid lens for years, had done really well with it, but in the past year before I changed him over, he had started to develop some corneal neovascularization because of the way that lens was fitting and the low decay skirt of the lens that he was in. So I refit him in a scleral lens. I just did a high decay material, and I keep his clearance fairly low, under 200, somewhere around 150. He's done great. His neovascularization has not gone away, but I didn't expect it to. It has not gotten any worse. Whereas the year before that, in his hybrid lens, he had been getting worse. You do want to keep in mind too that in some cases of corneal neovascularization and scarring, these lenses can actually help to improve and heal that. In patients, let's say for instance, an exposure patient who's developing scarring and neovascularization because of corneal exposure, once you cover that cornea up, it will start to improve. Patients with Stevens-Johnson syndrome, that sort of thing, you can actually see significant improvements in corneal health even once there's neovascularization and scarring, once you take away that exposure component. All right, so let's get into some lens fitting basics. Let's talk a little bit about equipment needs. So I like to put equipment into two categories, pretty much anytime I talk about specialties, and that is must have and nice to have. So let's talk about what you must have to fit scleral lenses. You've got this, I'm quite sure, in your exam room right now. That is a slit lamp and sodium fluorescein. You might even be able to get by without sodium fluorescein, but probably not. You probably need that. Nice to have in that category goes an OCT, topographer, and an anterior segment photo and video. So as we go through fitting basics, I'm going to go through both if we're fitting a lens just with a slit lamp and sodium fluorescein, and I'm going to show you and talk about what the process would be like if we had an OCT, if we had an anterior segment video, photo and video. So the first thing that you need to do when you're going to start fitting scleral lenses is if you to choose your lens design. Pretty much every gas perm lab has a design that they sell. They're all great. There's lots of them. You just got to pick one, right? So these are some of the common ones. There's more than this. I just picked, 6 or 7 of the most common ones, the names that you'll hear on a regular basis. But honestly, they're all great. They all have great consultants. Take your pick. You just want to pick a fitting set to start with. First fitting set that I started with when I first started fitting Scleral lenses was the Amplify set. So I'm going to be talking, a little bit about that set, but honestly, they're all great. And the fitting characteristics and the principles are the same with all of them. So you've chose a set, you've got it in your office, now what? So you're going to choose your diagnostic lens from the fit set. You're going to follow the fitting guide. As you're going to notice as we go through the rest of this talk, I'm a big fan of keeping it simple. So you're just going to follow the fit guide. We don't have to reinvent the wheel here. Okay, so fit guides for scleral lenses are a little different than fit guides for a typical lens. They are going to be based on lens depth and the condition that you're fitting a scleral lens for. Okay, so you can see in this fit set, this is the fitting guide here. It literally fits in one paragraph. You're either going to start with a lens, a 4000 sag that's for a normal depth cornea. That means your normal eyes. Okay, so that is, maybe somebody that you're fitting for exposure, ocular surface coverage, irregular astigmatism, but they don't have any ectasia. That's also going to be your pick for oblique corneas. So that's going to be your post-LASIK, your post-RK, your post-PRK. Then you've got a median depth, because remember, we're fitting based on sag or sagittal depth, not based on base curve. Medium depth is going to be for your run-of-the-mill keratoconus, your pellucid marginal degeneration, and then you've got high depth, right? And those high depth lenses, that's what you're going to choose first for advanced or bulging keratoconus, your post-keratoplasty patients. So what you're going to get in most fit sets, at least in the one that I started with, you're going to get a lens that's recommended. So let's say I'm fitting a keratoconus eye. I'm going to choose a 4400 sag lens to start. And then you're going to get about 200 microns of sag, more and less than that. Okay, so I might have a 3800 sag, 4000 sag, and 4200 sag. So you're going to choose the lens that fits the condition that you are treating. Then you're going to prep the lens and apply it to your patient's eye. So I'm going to play the video here in just a second, but the basics are you're going to fill the lens with sterile filling solution. You're going to use a sodium fluorescein strip to instill some fluorescein to the bowl. Let me go ahead and start this. So you'll see me putting the lens on the inserter. You just want to try and get the lens as centered as possible on that inserter. You'll see it has a little hole in the middle. So as you're putting it on there, you squeeze it, and then once you've got it centered, you let go and it's going to stay on there. You see me filling it with filling solution, and you want to overfill these. There should be a meniscus at the top. As a matter of fact, you want it to look almost like that solution is getting ready to just pour out of there. I'm going to give my patient a paper towel or a towel and have them hold it in their hand and then get their head as parallel as possible to that paper towel. That paper towel is there because we are going to get saline that is going to goosh right out of this, and it's got fluorescein in it, and we don't want it to get all over them. You're going to have the patient hold their lower lid in place. You're going to hold the upper lid, and then watching from the side, you're going to bring that lens into contact with the cornea. I always like to warn my patients that it's going to feel wet and cold when it comes into contact. Once it's on the eye, you're going to squeeze to release that plunger, and then you're going to inspect for any bubbles. And that's it. That's getting a lens on your patient's eye. Okay, now we're just going to evaluate the lens fit. First thing that we're going to evaluate is central clearance on the lens. When you put these lenses on, you want to let them settle for about 20 to 25 minutes. That is because the conjunctiva is spongy. Okay, so the lens is going to sink into the conjunctiva an average of about 100 microns after 20 to 25 minutes of wear. So you want to wait to do your initial evaluation. You don't want to look at a lens before that 20 to 25 minutes and see way more clearance than you're going to need and assume that you need to make a change to that lens, only to change it and find that now we have touch. Okay, so put the lens on and then wait that 20 to 25 minutes before you do any evaluation. The first evaluation that you're going to do is you're going to estimate central clearance at the slit lamp with a narrow slit. Okay, so on the left, you see what that looks like at the slit lamp with a narrow slit and white light when we have instilled fluorescein into the bowl of the lens. And on the right side, you see what it looks like when there's no fluorescein in the bowl of that lens. I wanted to include that because we're talking about that initial fit right now. But what's going to happen is once you find a lens that you're happy with and you dispense it to your patient, they're going to come back to see you for follow-up with that lens already on their eye. And so you need to know how to assess it without fluorescein as well, because you're not going to take the lens out, put fluorescein in, have them put it back in. That would negate the reason for having them come in for follow-up after wearing it for a few hours. So I wanted to show you the difference between the two. So over on the left, what you can see where the white arrows are is the lens thickness. Okay, so that is the scleral lens. Most lenses are around 250 microns thick. Okay, where the red arrows are, that is your tear reservoir. Okay, so that's your clearance amount. And then obviously the black arrows is your corneal thickness. So what you're going to do is you're going to compare the thickness of the tear reservoir with the thickness of the lens and estimate how much tear reservoir thickness there is. Okay, so if you estimate that your lens is approximately 250 microns thick, and then you look at that tear reservoir and you're like, yeah, it looks about the same. Great, there's about 250 microns there. You can also compare to the corneal thickness if you know what the corneal thickness is. All right, and then same thing without fluorescein. It's just a negative space instead of the green fluorescein that you see there, but everything is in the same place. And once you get familiar with this, you can easily estimate what your clearance is. Or if you have an OCT, you can use your OCT for central clearance. This is my favorite way to do it. I do it both ways, but I like to use my OCT. So if it's available, absolutely use it. I think it's a little bit easier for beginners. So what you're going to do there is you're going to use an anterior segment OCT. If you've got it, sometimes you can zhuzh like a 5 raster or 7 raster scan to give you this if you don't have an anterior segment module. But if you've got an anterior segment module, that's the way to go. So you can see your cornea there, you can see the lens, and then usually there are like calipers that you can use to measure central clearance. So again, central clearance, we want to be somewhere around 250 microns after that 20 to 25 minutes of wear. Second thing that we're going to evaluate is limbal clearance. So the lens in the transition zone, so the zone between that central optic zone and where it lands on the sclera, should fully clear the limbus. Okay, why? Because that's where limbal stem cells are. We don't want anything pushing on, rubbing on, irritating that limbus because we're likely to end up with limbal stem cell deficiency and an unhealthy cornea if that's the case. So we have to make sure that it fully clears the limbus. It doesn't have to have a ton of clearance there. As a matter of fact, you don't want a huge amount of clearance there, but we do need to completely clear the limbus. So to use a slit lamp to do this, we've got the sodium fluorescein in there. And basically what we're going to do is we're going to put a blue, a cobalt filter. And then I like to hold a Ratten filter in front of my light as well. And we're just going to look at all 4 quadrants of that lens to make sure that the sodium fluorescein goes past the limbus. Okay, so second way that you can do that, again, is we can use an OCT. All right, so when I do this, I use my anterior chamber angle module in the anterior segment to look at this. I just take that little line and I move it temporally and nasally. Or you could use, if you've got a pachymetry module, if you've got optical pachymetry, you can use that as well. So basically, we're just going to do a scan of that transition zone. You can see where the limbus is here. I've got it marked for you with that arrow. On the left, you can see there's no clearance, right? That lens is pushed right up against that limbal area. That's not a great fitting lens. That's going to cause some issues. On the right, you can see adequate clearance. Again, it doesn't have to be a huge amount of clearance. As a matter of fact, too much clearance can make them hard to remove. But we do need clearance, and that is an adequate amount of clearance if we look at it with OCT. Now we're going to evaluate the landing. So this is the edge of the lens where it actually sits on the sclera. We're going to use our slit lamp again to assess for 2 things. We're going to look for compression or impingement, and we're going to look for edge liftoff. So with compression or impingement, biggest thing that you're going to look for is conjunctival vessel blanching. With edge liftoff, you can look for a shadow at the edge of the lens. You can also look for any visible air bubbles in there. So just a tip, if you put a lens on, you check it for air bubbles, there are none, and then you come back 25 minutes later and you find some air bubbles in that reservoir, generally they're going to be hanging out in the quadrant that has edge liftoff, if it's in multiple quadrants. So we're going to check all 4 quadrants. Not all scleras are spherical. As a matter of fact, most of them are not. So you're going to check all 4 quadrants, and you're going to look for compression or edge liftoff. All the way to the left, that's pretty obviously compression. I mean, the conj is literally bulging out over the edge of the lens. That one's pretty easy to see. Middle one is what I'm talking about when I say you're looking for conjunctival vessel blanching. So when we have that area, we've got some injection, and then we've got an area of blanching, and then more limbal injection. That is a lens that is compressing. And then over here, all the way to the right, is a lens that has some superior edge liftoff. Once again, we can use OCT to evaluate these as well. So you just want to position your scan so that it's getting the edge of the lens. All the way to the left is a good landing, right? That looks great the way that it lands over there. The one in the middle is what you can call towing. That's compression, okay? And then all the way to the right is edge liftoff. You can see that compared to the left one, that lens lifts just a little bit at the edge. Not only are you probably going to get some bubbles, maybe some fogging with that lens, but it's not going to be very comfortable either. Okay, so we've got a lens on. Let's say we looked at it. It's got good central clearance after 25 minutes. We've got limbal clearance. Our landing looks good. Now what? Now we're going to over refract. Okay, so with the lens on, we're going to over refract to see what the difference is to get us to good quality vision. Do not be afraid when you're over refracting with a lens like this if you're getting very high plus or very high minus over refractions. You might have a patient who is a -3 who ends up in a plano powered lens. You might have a patient who's a +1 end up in a -2 lens, right? So what I recommend when you're over refracting these, because often even with these diagnostic lenses on, patients cannot see extremely well. What I recommend is go really far into the plus, put a big letter on the chart, bring them back down until they see it, and then start from there. Okay, so you're gonna over refract, but then what? right? You've got all this information that we just gathered, but now what do we do with it? I think that's where a lot of people get really intimidated is, they can look at a lens and say, okay, I can understand clearance. I know what that means. I know that I need to clear the limbus. Okay, that looks like it's pretty good landing. Or they look at it and they say, okay, I know what's not right, but I don't know the changes I need to make it fit better. Okay, so that's what we're going to talk about next. Lab consultants are your absolute best friends. Okay, you do not have to reinvent the wheel as you are learning these, or even like I've been fitting Scleral lenses for a decade plus, and I still lean on my lab consultants. It's literally their profession. It's what they're paid to do, is help you solve lens fitting problems. Okay, so use your lab consultants. What I like to do is anytime that I'm fitting a new lens, I'm doing OCTs, I like to video and photograph those lenses as well. And I take all that information and send it to my consultant. So I'll send them a topography if they need it, slit lamp video, OCT images. I'll tell them, my observations on the lens, what my over-refraction was, and then I just ask them what they recommend. Then I like to ask them why they recommend it so that I can learn. And then I'm going to repeat as needed. So I'm going to send all my information to them, ask what they recommend, ask them why, order that lens. The patient's going to come in. We're going to try that lens. We're going to assess it again. Hopefully, I'm going to get to dispense that lens. But if not, if there's more changes that are needed, I'm going to repeat as needed. Common fitting challenges, things like lens fogging. That's typically when you're getting proteins and cells into the reservoir, and it's causing fogging issues. Conjunctival prolapse, if we've got some loose conjunctiva and the lens is not fitting exactly right, the suction forces will actually suck that conjunctiva into the lens reservoir. Corneal edema, right? So if you're getting corneal edema when your patient's wearing this lens, we want to fix that. You're going to take these challenges to your consultant and they're going to help you solve them, right? So moral of the story there, use your consultants. Then we're going to dispense the lens. Once we find one that fits well, we're happy with it, we're going to dispense that lens to the patient, and then we're going to schedule follow-up. So at the dispensing visit, we're going to teach patient insertion and removal. We're going to wait 20 to 30 minutes and go through our evaluation process again. And if everything looks good, we're going to dispense that lens and we're going to schedule them back for follow-up in 2 to 4 weeks. So I typically have patients come in for a diagnostic fitting when I'm using my diagnostic lenses. I'm taking that information and along with my consultant, I'm ordering an initial lens and then I'm scheduling the patient in for a dispensing visit. Okay, so I always let patients know there's a possibility you're going to come in for this visit. I'm going to evaluate it and I'm not going to like it. I want to make more changes. But the plan is hopefully to dispense that lens at that dispensing visit. So we're going to teach the patient, evaluate the lens again, and if everything looks good, schedule them back in 2 to 4 weeks. At the next follow-up, we're going to do a couple of things. I'm going to answer any insertion, removal, or care questions they have. I'm going to ask them, how's it been going? How is it to put the lens on? Is it coming off okay? Or, any questions about how you clean or care for this lens? So we're going to go over all of that. I'm going to evaluate the lens on their eye. They're going to come in wearing that lens, hopefully a minimum of 4 hours of wear the day that they come in for follow-up. Full day is even better. We want to evaluate once we've had a chance to completely settle on eye. And if I feel like there's changes needed for a better fit or vision, I'm going to consult with the lab again. Okay. If the lens is a good fit, they're getting good vision, I'm going to schedule them for follow-up in about 2 to 3 months. I'm just going to share this with you. This is a video available on YouTube from Contumac. But there's lots of videos like this that walk patients through insertion removal. I like to use videos like this so that patients have something to refer to at home. Oh, let's turn
Is
sound on.
place the lens onto the tip of these 3 fingers that make a tripod.
So he's showing him what's called the tripod method.
With fresh
I like
saline.
using a
To
inserter
the
plunger
point where you've actually
better,
got a meniscus
but this is
over the
another
top,
way that you
almost
could teach your patients.
filling. We're then going to lean over, have the
You can see that
mirror
meniscus was
horizontally,
overfilled.
so you can see what you're doing. This is the tricky bit. We're going to need to put this finger onto your lower lid, over the top with the other hand, open wide, and then gently raise the lens against the eye. It'll
I really
feel
like this because
cold
it
as
gives the
the
patient
solution
an up
touches your cornea.
close
Just
view
relax and
of
gently but
what
firmly
they're doing.
press onto the eye. And we'll just show you that again. So pulling down, lift the top lid, gently press the lens against the cornea, ready for the cold sensation. Press firmly and release. Okay, so we're going to come to remove the lens.
I really like to use
again,
videos like
sure
this,
clean,
again,
all,
just because it makes it
sucker.
something
Take
easy
the
for the
sucker, lean
patient
forward
to
this time the mirror
go
can
back
be
and
at
watch
45 degrees
again
or
at
even
home.
vertical if it's
Good
more
reminders of
You're going to lean
exactly
forward, pull the
how
lower
this is
lid
done
down.
when I'm not there
Make
to
sure
answer
we
those
can
questions
see
from.
the lens. Press the sucker, expel the air. Place the sucker against the lower half of the lens. Release
I like to use
to
a
get
smaller
some suction, and then lift
DMV
up and away. Do
plunger
not
for
pull
this.
straight forward.
I don't use the
Just
same
lift
one
the
for
bottom of the
insertion
lens
removal,
to break
but
the
you
suction, and then the
absolutely
lens should
could
come
use
away
the same one.
cleanly. Pressing firmly against the lens, release the suction and lifting up and away from the bottom edge of the lens.
You can also have your patients, when they do that, just take that bottom lid and just gently kind of push against the sclera just outside of that lens to kind of break the suction a little bit. But again, love videos like that. They're very helpful for patients when they're at home and they don't have you right there watching them and coaching them. YouTube is great for that. All right, so what's some practical info to know as you start this process of fitting scleral lenses? What kind of supplies are we going to need? So patients are going to need filling solutions. There's lots of different filling solutions that you can recommend. I've got a list here: Scleral fill, Neutrofill, Pure Lens, Lacropure, the sterile inhalation solution. The Scleral fill, Neutrofill, Lacropure, those are all sterile saline, but they have different additives, different buffers and things like that that make them more comfortable for some patients. I like to keep samples of these in my office, and I'll typically send a new scleral lens wearer home with a couple vials of inhalation saline, a couple vials of Neutrofill, a couple vials of Lacropure, so they can try the different ones and see what's most comfortable for them. Pure Lens is kind of cool. It is sterile saline, but it's in multi-use bottles. Obviously, all of these are preservative free. We need a removal plunger, and we need an insertion plunger. Got a couple options for cleaning and disinfecting. Clear Care works great. Most scleral fitters look for it without Hydroglide if you can find it. It's really hard to find it without Hydroglide. But if you can, that's best. Unique pH is another one. It's a multi-purpose. Tangible Clean is also a multi-purpose. And then, some of my patients use an ultrasonic case. So we'll use like a Unique pH or Tangible Clean in an ultrasonic case to clean it. You can also just do a rub rinse in store with these. Follow-up schedule for a new scleral lens is going to be at approximately a month after dispense, 3 months after dispense, 6 months after dispense, and then every 6 months or less, depending on the condition that you're treating and the condition of their cornea. Chair time that you can expect, maybe a little bit more than this at first when you're just learning the ropes, but eventually the initial fit takes about an hour. I'm not with the patient for the whole hour. I will often chat a little bit, put the lens on, and then I leave them for 25 minutes or so to see another patient, and then I come back to evaluate the lens. The dispense visit, also about an hour. For the same reason. You're probably doing some training. You've got to leave the lens on for 20 to 30 minutes again to evaluate. When they come in for follow-up, when they're already wearing the lens, about 20 to 30 minutes is pretty typical. That means that you're spending a minimum, if everything goes really great, of 3 hours of chair time to fit, finalize, and monitor for the first year. So the next thing I'm going to say is make sure that you are charging appropriately for your chair time. Okay. Chair time calculators are available online to help with this. I'm going to share with you one that I have used in the past. Dr. Wu on her website actually has a great chair time calculator that I'm going to share the link for. Keep in mind that these lenses often are considered medically necessary or visually necessary, and they do have some insurance coverage. It depends on the condition that you're treating. Even within, let's say vision insurance, like one insurer, that they define those conditions differently than another one does. So you definitely want to check your vision plan provider manual for coverage specifications and details. You also want to make sure that you are checking to see if you need prior authorization. There are some even vision plans that you have to get prior approval for. Hopefully they're telling you in that prior approval what they're going to cover and what amount. You want to also check to see, is it covering fit and materials in full? Is it covering just the initial fit and materials, but you are allowed to charge their medical plan for follow-ups? Those follow-ups aren't so much about the fit of the lens, they're about the health of the cornea. So that is a medically necessary problem-focused visit on their medical insurance. Medical plans rarely cover it, but if a patient is telling you that their medical does cover it, predetermination, pre-authorization is an absolute must. Have it in writing. I would have your patient sign an ABN stating that if it is not in fact covered, that they are aware that it is an out-of-pocket and they are expected to pay for it. Here's some helpful resources. GPLI, the Gas Perm Lens Institute, is fantastic for all things gas perm related. They have a Scleral lens fitting guide that is very in-depth. I would check that out. The fee calculator that I was talking about is at this website. It's Dr. Wu's website. You can go through and calculate fees on there. And then the Scleral Lens Society also has tons of resources for practitioners who want to start fitting scleral lenses.